determined, because what happens is it's draining for the doctor, it's time consuming, and it's really very expensive. So determining brain depth, we need an organized, rational approach that can adapt to the variable journey of the patient's disease, wishes, and the family. And the family is oftentimes one of the most important aspects you're dealing with. The more brain depth determinations you've declared, the greater the spectrum you see over the years especially, and the variable settings that you have to deal with. And I think that's important, because over the years, when you just have done one or two, you don't see the spectrum of all the interactions that really take place. For the doctor in this individual case, and for the family, it's a gradual education process. You have to get the facts, communicate, and that's probably one of the most important aspects. And as mentioned, it's determined by two doctors, almost always. Here, in my experience, it's by two neurologists. And when you can, get the basics in writing. And the writing is very important for me, because if there's going to be a legal issue later on, having things in writing is very important. So brain depth, a discussion and decision that must be individualized and tailored to each patient and each family. And that is really key. Now the AAN guidelines, Dr. Vega is going to talk about, but I want to emphasize these are guidelines. They're guidelines. And it states right in there are options. Now that is entirely different than the legal issues that can come about. They may not hold up in court. They may have some, but oftentimes the legal issues are not necessarily followed by the guidelines. These are practical guidelines. They're practice guidelines. I'm going to just mention four key things, factors in brain depth, just quickly. Number one, it's the patient. Age, the younger the patient, that's always the most difficult. It's more difficult for the family, the friends, and the relatives. The diagnosis, each diagnosis gives you a unique setting in the determination of brain depth. Trauma, stroke, anoxic encephalopathy. Probably this latter one is very difficult because you may have ongoing myoclonus early, or you may have activity in the EEG that suggests a suppression of consciousness that and you're using lots of drugs to help treat this. And of course, comorbidity has already been mentioned. The second one is the disease, and I briefly mentioned that. It depends on the disease that the patient has, how you may approach this. We see a lot of trauma here, focal strokes, hemorrhage, intraventricular hemorrhage that brings about demise, then it calls the anoxic encephalopathy. Now the third key factor here, I think, is the one that probably gives us the most difficulty, because by and large, in my experience, most brain depth determinations go quite well. It's the ones that don't go well, that have the complex issues, that really are a problem. So the family comes in. How much education do they have about this? What's their understanding? Are they really unified in their concept about depth and brain depth? And then the question is the family unified? Or is there a lot of difficulty with struggles of personalities and issues and concepts in the family? Now, if the family is involved with a legal potential case, such as improper care prior to this, or financial considerations, someone later on, the physician, and if it comes to court, which I've already been involved, maybe not for cases of my own, but about 6 cases, someone is going to have to defend the process and the action by the doctors and the clinical staff. Now the other aspect is kind of this baggage. That's kind of a term that maybe isn't so desirable, but the baggage is very important. Every family has their own. There may be divorces, multiple parents, there may be multiple children that are involved in older patients. Neuropsychiatric disease. About 8 years ago, we had a patient who had a relative that had a known psychiatric disease. Very difficult to deal with. And of course, the Shivo case, even though it wasn't brain death, has complicated this issue and shown that there's a certain number of difficulties that could occur privately and in the paper and legally. Now the treatment aspect is also important. A lot of people forget this. The treatment journey to the development of brain death is key, because you may be given barbiturates, anti-epileptic medicines, or paralytics. The barbiturates oftentimes is really an important aspect. Now, most of these people are intubated, and oftentimes now we're seeing aggressive surgical approaches to patients that have hemorrhages or brain ischemic changes, and we're changing the format that we really have. And of course, the drug and metabolic aspects are important. Now, this is a statement that everybody knows, but sometimes it's amazing how, as you review a case later, it's not really held to. The doctor's obligation is to the patient, morally, ethically, and legally. And that legally part is really important. The doctor is legally responsible for all that transpires. Now, in most hospitals, brain death is a clinical diagnosis supported by tests. Now, 38 years of experience in this, I can tell you, here's some of the things I really think we need to do. Number one, if you think that there's a drama or a crisis that's developing, some way try to get out of that. Avoid crises, avoid drama, especially with families that have disparate concepts. The doctor is legally responsible. Listen to the baggage. Listen to the nurses, listen to the doctors, and listen to the family. I really believe if everything is not just right in a case, you've got to be careful. The biggest issue there is if there's a legal complication coming up. And then expect the unexpected. Make sure everyone is on board, and there should be only one MD, I think, in charge, and that may be the primary doctor, it may be the neurologist, it may be the intensivist. So the lessons that I've learned are, do not learn lessons in the same difficult cases again. If you've had a difficult case 10 years ago, try to remember that case, and if it applies to the new one, be careful and remember. Remember the history. Human behavior repeats itself. Now, the other important thing, and this was a case I testified in about 6 years ago, read the tests exactly as they're typed. If the test says suggest in a nuclear medicine test report, that's exactly what it says. It doesn't say definite. It says suggest or maybe. That's key. Now, I did a survey of 20 neurologists at the AAN. Most of them were head of the departments. And here's what I came up with. Number one is there's no unified approach to how to determine brain death. We got guidelines from the AAN, and I won't comment about how always those come about, because there's lots of guidelines. But it's a spectrum most people really are exhibiting. One of the chief of neurology told me, he said, it depends on who's the attending that month. Everybody had their little different thoughts on how they determined this. Almost everybody had some supporting tests. Some didn't. Now, some of the centers avoided EEG, if possible, and that usually comes from the concepts from Posner and Plum, because they know the pitfalls that Dr. Della Vega will talk about the EEG. Now, this is a statement that most of the neurologists said. Never let the organ group or the transplant team be involved with the patient early before the diagnosis. The reason is, the concern is it may alter the treatment format. Now, you may think it may not, but if it's retrospectively looked at, some people are going to say that. And avoid trouble, we talked about the Shivo. Now, here's my suggestions. Number one, we need a general education and plan presented to the public here in San Diego County and to the doctors about brain death. Now, this is an educational process. Now, we all know if you have a patient and family that's educated, it's going to be an easier process to determine any kind of medical care. I recommend a county-wide basis and format for this. A public awareness program. Now, this has been done in other areas. For example, look at our stroke program and the Clot Buster. We have educated the public to a great, significant number about when to get patients to the ER in a stroke. That we can easily do, I think, in this. So who's going to spearhead this? This could be Scripps, it could be somebody else, but I think this really needs to be. So in summary, we want to arrive at the diagnosis of brain death, and you need to do it in a rational, reasonable, organized approach that understands all aspects of the patient, the family, and it individualizes and tailors the process. Thank you. At the end, we're going to do questions.
This is going to be kind of a technical talk, but I'll breeze through part of it when it gets a little bit dense. Basically, this is how we determine who is brain dead on the clinical examination. The clinical criteria for brain death: the patient has to be in coma, there has to be absence of brainstem reflexes, and the patient must have apnea on the apnea test. The prerequisites for adults and children: there must be proximate cause of injury, and it has to be demonstrably irreversible. You have to rule out severe electrolyte, acid base, or endocrine disturbances. The patient must be warm, above 32 degrees or greater. There has to be absence of evidence of drug intoxication, poisoning, or neuromuscular blockade. And neuroimaging must be compatible with the acute cause that could cause a brain death. But if the imaging looks pretty normal, you may have to consider spinal fluid for things like meningoencephalitis. It is a clinical diagnosis, must be performed with precision, findings must be documented, and independent confirmation by a second licensed physician, at least here in the state of California, must be done, preferably either a neurologist or neurosurgeon. The coma examination, the patient doesn't respond to anything induced them. Any sort of noxious stimulation to the supraorbital ridge, the TMJ, or to the nail beds and all limbs, or a chest rub, or any sort of pinching anywhere. Then you go to the brainstem examination. You look at the pupils in a dim room, bright focus light beam, and there should be no constriction of all the bright light. The eyes are in mid position. They are either round or they can be oval, and they can be from 4 to 9 millimeters in size. When testing the ocular movements, you can try the halsey maneuver, where you turn the head side to side with the eyelids pried open to see if the eyes stay kind of where they should be, or they go with the head. But if the patient has any question of cervical instability, you should not do this test because you'll break their neck. Then we go on to the cold calorics. First thing you do is check the ear canal, make sure that they do have an eardrum that's nice and good. You shouldn't do it if they have a hole in it. Put any wax. Clotted blood may dampen the test results. And you instill about 50 mLs of ice cold water at the bedside with the head tilted up 30 degrees to the bed, with the emesis patient under the ear so nothing else gets wet. And over about a minute's time, you look for eye movement to the side of the stimulation. Then you go to the other side, but you wait 5 minutes for the head to warm up again. Then you test for grimacing. You can test for corneal reflex. You can check for a jaw jerk. And then for the lower brainstem, you try and see if they have a cough or a gag. You should directly stimulate the back of the throat with a tongue blade or a swab stick. Just wiggling the tube isn't adequate stimulus in many cases. Any sort of suction without response means that they're not going to really cough up. Apnea testing is the last thing we do in certain patients that meet requirements. The patient has to be a little bit warmer than the earlier prerequisite temperature. Their blood pressure should be above 90. They should have good fluid balance over the last 6 hours. And they should have normal oxygenation prior to the test. What it does is by blasting with a bunch of oxygen, you get rid of the nitrogen stores. and they should have a PCO2 that's adequate. You should disrupt the patient so you can look for any sort of breath movement of the chest. You should have the pulse oximeter on. And you turn off the ventilator, but you still continue a flow of 6 liters per minute of oxygen at the level of the carina. And you measure with the ABG before and after the test. After the test, about 8 minutes, because the average rise of PCO2 is about 3 to 4 millimeters of mercury a minute. If respiration is observed, the test is negative. The patient does not meet clinical criteria. But if no respiration is noted and the PCO2 is greater than 60, or there's a 20-point difference from baseline, then the test is positive. You should reconnect the ventilator if bad things happen, such as if the pulse ox reading goes down, blood pressure drops, or arrhythmias develop. The test is indeterminate if you don't get to that if it's less than 60 PCO2 mark, or the change in baseline is less than 20. There are pre-existing conditions that can complicate this. Poor oxygenation, cardiac arrhythmias, hypotension, and electrolyte abnormalities. From Mayo Clinic from one of my old colleagues, they looked retrospectively at 121 patients, but they tested apnea 145 times. And about 48% of the time, there was some trouble with the prerequisites. 20% complication risk. Most of these happened in people that had the unfavorable pretest conditions. Inadequate pre-oxygenation was the biggest cause. The biggest complications were hypotension, and then one patient had arrhythmias. According to the guideline, you should have intervals in according to what age you are when you have this test done. If you're turned to 2 months old, you should have the test repeated in 48 hours. If you're between 2 months and 1 year, it should be 24 hours later. From 1-year-old to 18-year-old, it's about 12 hours. If you're older than 18, it's optional. There's pitfalls that we see. Sometimes all the testing cannot be done because there's facial trauma. The pupils have irregularities that were there before from surgery or whatnot, and the patient is still under the influence of various drugs. Or the patient can't have the apnea test because of COPD or bad asthma or other problems like that. And you absolutely have to run a locked-in state. Sometimes people will look at what the patient's doing and assume that, oh, they're still conscious. But these should not be misinterpreted as conscious or voluntary movements. Some patients will have movements of limbs. Some will have alpecitonis, sweating, blushing, tachycardia. They will still sometimes have deep tongue reflexes and have spontaneous triple flexion response where the leg seems to jump in bed when the sheet is moved over the foot. They still may have Babinski. Especially in little children, they may not have fully developed brainstem reflexes, and it's hard to do an examination with your arms inside an incubator sometimes. Now, the confirmatory tests are not mandatory and are optional. They're desirable in patients in which the other parts of the exam cannot be done safely or with good judgment. They are recommended in children less than 1 year old. According to the California Brain Statute, may be used to support clinical diagnosis, not required by law, but may be required according to the attending physician or the hospital policy. So it's optional in that way too. If you're a little baby, you should have 2 of these things done. If you're greater than 2 months but less than 1 year, you should have 1. It's optional between age 1 and 18, and it's optional greater than 18 years old. The confirmatory tests that are commonly done are the EEG, formal 4-vessel cerebroangiogram, transcranial Doppler if available, and the isotope study, this long name. Scripps uses a different one called Neurology, which is probably similar to this, using technetium. Evoked potential sometimes are used. I won't go into the last one. There's only one article that I was able to pull up on that. EEG can provide confirmatory evidence of brain death. What you should see is absence of electrical activity over a certain, no activity over 2 microvolts in sensitivity. These are the techniques that should be used when doing the test, and this is all kind of technical. And one of the things is, passively, is there any activity? And when you stimulate the patient with noxious stimulus, is there any sort of activity? And if there's doubt, repeat the test and try and eliminate all external sources of electrical interference if possible. You may not be able to, especially if it's a ventilator. It has pretty good validity. There are some pitfalls. Sedation will affect this. External electrical activity and interference will affect this. Sometimes it's the operator's experience, sometimes it's the interpreter's experience. An article about 20 years ago, from which we still draw from, about 20% of people will still have some sort of residual activity of some sort. It's usually abnormal anyways. And then also the EEG really measures the cortical and subcortical activity, not so much the brainstem at all. Angiogram, it's invasive, but what they do is they inject dye into the aortic arch to see the anterior and posterior circulation simultaneously. There should be stoppage or arrest of flow at the foramen magnum for posterior circulation and the petrosal portion of the carotids for anterior circulation. There should still be, the external carotid should still be paved, and you'll see a delayed filling of longitudinal sinus. According to Dr. Vadix, who's one of the main brain death people in this country, there's still no intra-observable studies. There's no interpretation guidelines, again, of different radiologists. You can still, in some cases, have residual perfusion, even if the EEG looks flat. And it's still an invasive study. The patient may not be able to be transported to the angio suite. Transcranial Doppler is basically an ultrasound tool that they put over the cranium, over the temporal bones here, to look at the MC, the vertebral basilar, by going back here. And you look for either lack of flow or small little waveforms that are indicative of high ICP. 10% of us do not have good windows over here anyways, and lack of flow may not be a valid confirmation test because 10% of us don't have that flow, unless earlier in the course of the hospitalization you proved that the patient had flow earlier. It's about 91% sensitive, 100% specific. It's affected by the carbon dioxide, hematocrit, and cardiac output. It's operator dependent. It's useful in patients where you can't do the EEG or apnea test because they're still loaded with barbiturates. 20% still have flow in the internal carotid artery for whatever reason. And you still may show normal blood flow signals if the lesion is mostly infratentorial or it's kind of a diffuse anoxic ischemic change. The isotope test is a bedside examination with this isotope in particular. They recommend getting images immediately after injection, half hour, 1 hour, and then 2 hours later to see if there's any pickup. You should see no uptake in the parenchyma of the brain, and the isotope should be injected 30 minutes after you mix it. And to check to see if the injection was true, you should check the liver to see if it gets picked up there. 94% sensitive, 100% specific. If you just do anterior views, you will not see the brainstem. There's good collaboration in some studies with an angiogram, but it's still operator dependent. Evoked potentials is basically taking electrodes, putting electrodes on the head and shocking the limb and see when the brain picks up that signal. But if you have a high cord lesion from a trauma, it's not going to get to the brain on a false reading, and we're still awaiting validity studies. Those are the references.